Hello, everyone. Welcome to The Voice of Nursing. My name is Adrian Tracy, CEO of ICG Medical. Today, joined by Austin Purkeypile, the COO of AdventHealth, East Orlando. Welcome, Austin.
Thank you. It's my pleasure to be here, Adrian.
Austin, tell us a little bit about yourself.
Sure. I've spent the last 14 years as in various levels of hospital administration. Began my career as a financial analyst and really understanding, the cost drivers and revenue drivers of our system, and transitioned and started here at AdventHealth. Transitioned to the West Coast, where I worked at Stanford Children's Hospital as a service line finance manager, and then followed my wife's nursing career. I'm not a nurse, actually, as she went to CRNA school in Southern California at Loma Linda University, where I was the executive director of the International Heart Institute at Loma Linda. Spent another year in San Francisco as a VP of Strategy and Business Development for Dignity Health, and then have been almost exactly a year back here at AdventHealth East Orlando as the Chief Operating Officer.
So, for our clinical nurses and physicians who watch this, what does a COO in a hospital do? What are your sorts of responsibilities? Be quite interested to hear.
It can vary quite a bit depending upon the size of the facility and what other executives you're surrounded by. We have our team here we all report to a CEO. We have a chief medical officer who oversees all medical staff related issues. We have a chief nursing officer who oversees the nursing units, emergency departments, the operating room, and then I, as the chief operating officer, handle the other clinical areas, lab, facilities, security, and various. I have responsibility for our cath and IR labs, as well as overseeing strategy and finance for the organization.
And what would you say most sort of interesting, challenging part of your role is?
Well, we're in a high growth area, and we have also traditionally been, we're a very large emergency department at East Orlando. We see 125,000 visits a year. And so we have been undergoing over the last decade a sort of scaling up to go from a large emergency department with a few services around that to being a full-scale community hospital. So I think we've added 8 specialists over the last year, and we're recruiting for 6 more, as well as rounding out our primary care market. So I would say the growing pains that come of scaling up that operation and really being the level of community hospital that the East Orlando community needs and deserves. That comes with a host of challenge, but they're exciting challenges.
What would you say the top 3 are?
Well, I would say that staff workload and burnout would be number 1. As you don't just add we went from a very small diagnostic cath lab to growing into, later this year, we will have 2 full service interventional radiology and interventional cardiology labs. And you've got to build the cath lab team to be able to handle that, but you also need all the services around that to work in concert. And so I would say the challenge is in getting all of the support staff, the nursing departments, imaging, to support these services while also continuing to grow the rest of our patient volume. So it really has stretched our team to be both taking care of more patients and learning new services, and we're trying to recruit. That's part of how you and I started talking in the first place. But in today's labor market, and I guess I would say that is the challenge number two, we have very low unemployment. I think I heard that it was the lowest since 1969.
3% or something, isn't it?
Yes.
Yeah.
Yes. So very low unemployment, very healthy economy currently. And so pretty much anyone who wants a job is able to find a job in their field. So when you add to that Central Florida, where I'm located, has been rapidly growing, and it can be hard to find qualified staff who can meet all of your shift demands. So, and I guess you could throw in another factor to that, in that it's an aging population. It's a popular area to retire, and so typically, as the population ages, they work less or retire altogether, and then they start to require more healthcare needs. So when you put all of those together, it really does stretch our staffing. I would throw in a third factor of the overall pressure to adapt and change in our healthcare system. It, the healthcare system in America doesn't just change when we pass Obamacare or the Affordable Care Act. There are also constantly new regulations coming out, both at a state and federal level. Recently, Florida is just getting ready to sign into law a repeal of how hospitals have been approved for new facilities, called Certificate of Need. It's something it's a state by state thing that Florida has had for as long as I've known. And so when you wanted to build a new hospital, you had to prove that there was a need in the community. And so we had lots of systems built around that process. That has been repealed. And so we're expecting some flood of new competitors, and trying to think about how we take care of our markets in a way that they continue to seek us as their preferred provider. So I think those would be my top three, but maybe by lunch there will be three more.
Obviously, this is an international sort of podcast and blog, but could you tell us what, we hear a lot about Obamacare.
Yeah.
And also I've heard obviously about the Affordable Care Act. Could you maybe tell us exactly what those things are for our English listeners and Australians and so on?
Absolutely. So Obamacare was, and the Affordable Care Act, the same thing. So Obamacare has become the shorthand, sometimes a political weapon to divide. There are states where Obama is not popular, where it's called something else, and they don't realize that it's the same thing. But in essence, it was the big plan to take care of the largest gaps in the health system that we had, and the health system that we wanted to be. Now, with the great deal of compromise required when a party does not have a 2/3 majority, which almost never happens in the U.S., is that you have to get some level of buy-in from both your own party that is feeling local pressures, and oftentimes from the other party to get a bill across. That didn't actually happen with Obamacare. They needed every single vote they got, because not one Republican was willing to sort of compromise and break with party ranks. But it did pass, and it was designed to both put a set of reforms and sort of metrics around quality that and cost management placed on all providers, and also to close the gap in uninsured population. So it expanded our Medicaid programs that ultimately was struck down on a national level and became a state-by-state decision. So we in Florida, for instance, we did not choose to expand Medicaid, and there is still pressure to do so, but it's currently Republican controlled, and that's not getting off the ground. But it also created a set of subsidies such that people who were not near poverty level, but were certainly not wealthy, could get a certain set of subsidies to be able to more affordably buy healthcare. And they created an exchange marketplace where you could shop for plans that essentially were gold, silver, or bronze. Gold covers a lot, but it costs more. Bronze covers significantly less, but is more affordable up front. It also created definitions around what you could call health insurance. So before there were plans that covered almost nothing and cost significantly less, but when you would go to use it, you would find that these services weren't covered or you had a huge out-of-pocket cost.
Right.
And so they enacted a set of basic services that had to be covered and covered at a certain level to be called health insurance. So there's been much debate about that, but I think it did help decrease the complexity and the sort of advantage that a health insurer would have in terms of having more information than those who are purchasing the plan. So it helps standardize that definition.
Mm-hmm.
So there, coming with all of that was what was called the individual mandate that has recently been rolled back under the Trump administration. But the idea was that if you require everyone to purchase health insurance, or if you make it more affordable, you need to require people to have it. Otherwise, only those who are very sick will have the health insurance. And then you will, it's called adverse selection. You will have very sick having health insurance, and nobody who's really healthy is paying in to sort of balance the risk across the board. That's
Right.
recently been repealed. People feared that it would have a very destabilizing effect on the individual insurance exchanges. I wouldn't say that it has been cataclysmic from that standpoint, but I think that the legacy of Obamacare will probably be one that it standardized the definition of health insurance, and it expanded access to care for through the use of Medicaid expansion for the states that accepted it. And I think the number is between 20 and 30 million people who received access to care that had not previously had it before. So I think that will ultimately be the legacy. But it's interesting to see the debates that were argued very vociferously about points that ended up not being that terribly impactful when they were putting a new healthcare reform together.
Mm-hmm. And looking at your background, obviously, I know you did like an internship in the insurance industry. Is that right?
Yeah, that's
Yeah, back in the
quite
day.
a while
How
ago.
come you ended up in the healthcare space?
So I, unlike I would say most of the population, I actually enjoyed math quite a bit, and so I was looking for. I knew I didn't want to be a math teacher. I didn't want to teach people like me, but but in the insurance industry, we have roles called actuaries that really do all the math to set the rates for different insurance products based upon risk calculations.
Mm-hmm.
And so that was a field that I was interested in pursuing because it takes a lot of math knowledge to do that. I was fortunate to work at a company called Assurity Life Insurance in Lincoln, Nebraska, and get my experience there. But ultimately, I found I had some friends who were working in healthcare, and I found that a lot of my analytical side would be challenged there. But there was also the human side, and I very much enjoyed the human interaction of working in a hospital. And it so happens my brother, sister, and wife are all nurses, and so their influences kind of led me in the direction of healthcare, and I've been richly rewarded for choosing that field.
Obviously, with the family connection, what sort of feedback do they give you about the current challenges in the nursing community?
Well, I think that the pressure to always do more is certainly there, and also getting a feeling of I've used it a lot to bounce ideas off of them and say, you know, probably most people in most industries can be frustrated with decisions that are made that affect large numbers of people that they feel like they did not have a say in. And so I can use that as sort of a focus group within my own family to say, hey, if we were considering a change like that, how might that be received? Or what's the best way to get their feedback and to ultimately achieve buy-in, to say, you know, how can we create a better working environment? You know, what's the best way to involve nurses in training and get their input on the strategies of the hospital? So it's sort of the mini focus group, and of course we reach out to our nursing teams in a more formal basis at East Orlando, but it does give me sort of an area to bounce ideas off of.
You got a focus group giving you very honest feedback, I'd imagine.
Yes.
I know you mentioned some of the challenges facing the current US market. What kind of learns, or what, obviously UK is a very similar demographic from an aging population, and challenges in the workforce. Is there anything we could maybe learn from the US system that you think might be quite transferable over to the UK?
Well, it's interesting. When I've traveled in the UK, I've tried to do the reverse of what you're doing and just get insight into how people feel about their care. And it was one visit, I was asking about the access to healthcare, and they said, "Oh, you could wait a long time." And I said, "Well, actually, primary care you can probably get in today or tomorrow, but it's going to be, maybe 3 weeks to see a specialist." So, the U.S. sort of market-driven healthcare approach is supposed to be superior from an access standpoint. And then I was thinking back to, the area that I was managing in the U.S. that was waiting. There was like a 3-month waiting list to see some of our specialists. And so I would say, but what has sort of built around that are the variety of options in to maybe not see your primary doctor because he may be truly booked out that far. Probably he's a good doctor, or maybe he's the only doctor in your area. But the demand, the demands are tight to see the best doctors. But around that has sprung up a variety of access options. So we have urgent cares, at least in bigger markets here. We have emergency departments. Here at AdventHealth, we're building a number of freestanding emergency departments. So they have the same levels of service. They're just not attached to a hospital. And by and large, most patients can come, be treated, and go home. But those who need to be transferred, we have a quick transfer process to send them to our larger facilities. So just here at East Orlando, we're currently building 2 freestanding emergency departments. But then beyond that, we have a product called eCare, which is a telehealth alternative. You actually talk to someone at an urgent care, but you're speaking through your phone through a FaceTime-like app. So I would just say there are the more market-driven healthcare economy here has been instrumental in creating lots of different access points that probably probably not everyone needs to wait weeks or months to see a doctor. They may have a very basic question, and if you have a sort of triaging service to answer 80% of the questions via phone call, then the other 20% you may not have as long of wait times. But I wouldn't say that broadly we've achieved great access in this country, but we have that has sort of forced us to come up with different access points and strategies that probably could be learned from internationally. But I think the balance of there are so many different expressions of healthcare internationally that I think we have much more to learn in the U.S. about this than I would suggest that they copy us in terms of access.
Fair enough. Very, very kind to say. Obviously, you've been in healthcare, what, 10 plus years now? 12 years?
Yeah. 14. Yeah.
14 years, yeah. What sort of changes have you seen in that period of time? Sort of, big changes, and then what do you sort of think the future might hold?
Yeah. I think that there is because it has been so central to political concerns, the level of national acumen in the U.S. around healthcare, around what makes healthcare good or bad, I guess the literacy on healthcare topics has increased dramatically in the U.S. I think that's very healthy. So when I was growing up, I might hear my grandparents say, "Oh, I've got the best doctor," or "This is the worst." And that might be the extent to which you can do any sort of market intelligence about selecting a physician. Now you have health grades, you've got Google and Yelp reviews about the doctors, you've got Facebook and Twitter, and so you can do much more scrutiny. And that's just for physicians. When you're looking at facilities, there are many more objective lenses. We've got U.S. News and World Report, which has been around quite a while, but the Leapfrog group has a rating system as well. You have CMS, which is the government Center for Medicaid and Medicare Services, has their star rating system. So you get 1 to 5 stars, and then you've got measures below that rating the quality of the institution. So that all of that and the national debate really aids just the public being knowledgeable and ultimately holding accountable, either through their market choices or through town halls or online debates, whatever. But the literacy has raised substantially, and I think that leads us to demand a better product. And I think that is a very healthy dynamic. If our assumption that a market driven healthcare product ultimately gets us more innovation, then you need good information on which to make that decision. Otherwise, it's just the market system only works when you can make educated choices about that, about your options. So I would say that is the biggest change, and that has led us on the healthcare side to be much more consumer centric. We have many different ways of soliciting feedback from our patients. That leads us to find solutions and to sometimes create whole new products that they say are lacking For instance, we have rolled out a significant care coordination project where we have folks stationed in our emergency departments, but also more centralized folks who are just there to help navigate the maze of medical options and resources in the community that before an educated consumer might be able to do, but a new consumer to the system would be very challenged to do. Now we have professionals in that arena. So I think that all is positive. And while the scrutiny, you may not feel like they're scrutinizing the right things at the right time, overall, that's a huge positive to hold us all accountable to having a great product, because it's certainly not for a lack of funding in this country that we that folks should expect something less than any country in the world is offering.
What do you think the future might hold? You mentioned innovation before.
Yeah. Well, I think there's a whole market set of options. I think we're just beginning to scratch the surface from a telehealth standpoint. And so, might we one day be able to, let's say, talk to an oncologist in a physician's office locally, and then have 2 or 3 second opinions by the afternoon with a FaceTime call. Could be in the U.S., could be stationed somewhere else, but be able to converse about our healthcare, review different approaches, and hopefully have that tied into best practices and evidence-based medicine. So I think there's a whole market set of opportunities that we will see. But then there is the governmental side. And that really is a guessing game, about where we might be a year and a half from now.
It's the next election, is it?
Yeah. So the 2020 election, right now we're certainly expect that Trump will be seeking re-election and then facing a slew of Democratic contenders. It has become fashionable to profess on the Democratic side to profess support for a Medicare for all solution.
Mm-hmm.
Turns out that means a lot of different things to different people. We threw out I think Bernie Sanders said we will have Medicare for all and it will be free at point of use. That's not how Medicare works today. So we're, what Medicare for all is and what their healthcare plans are, and then ultimately who wins the election and who wins the Senate and House of Representatives campaigns that would have to vote something new into law. That is a gamble. So I would not care to predict where that goes. Just that it will be very important to the future of healthcare, and could go in many different directions. So there is one concern that when we say socialized medicine in other countries, that means so many different things. When you look from Australia, that has sort of and I'm definitely not the expert, so I'd ask you to weigh in if you would, but I believe it has sort of a 2-tiered system. So there's a public option, and then there is also a robust private option that you can buy above and beyond that. Canada really just has a single healthcare system that everybody accesses. And then would you say that the NHS is somewhere in between those two options, and that there are private hospitals, but also a very robust public one? But
yeah, the NHS is very similar to the Canadian model. Very similar. It's accessible. Yeah, no, it depends if you want to see that specialist very quickly, or you can pay for above or for different types of services from private hospitals. Some things the NHS won't provide, and that might be something, plastic surgery,
Sure.
Things like that, things that are of the nature of, kind of additional services. But for,
Sure.
your accident, emergency, your oncology, all that sort of stuff covered all by the NHS. Very similar to the Canadian model.
So the sort of radical, initially radical, but now gaining support on the Democratic side, the Medicare for All idea really isn't even to that level, because what they're suggesting is that the government become the provider of health insurance, but that's not the provider of healthcare.
Right.
So,
Okay.
we have, so our Veterans Administration, the VA, provides a sort of closed network product for veterans across the country. So that would be our best example of a what maybe a socialized.
Does that work well?
I would say broadly the answer would be no. But that's another way of saying that it has the same trade-offs that every other country has faced. Long wait times. You may be guided towards using your local facility when perhaps with more options you would seek out maybe a center of excellence for what you're seeking, as opposed to just you're sort of locked into one option and you're going to wait for a long time. So there have been various efforts to alleviate those wait times, which is usually involved giving veterans the ability to access options outside, i.e. the private healthcare network, and coming up with payment models to do that. So I would say that we have struggled to keep up with the need for healthcare, which I think is generally certainly is a critique in Canada, that you will wait a long time, and so Canadians will come to the US and pay out of pocket if they're well resourced to do so. But no, I think that I think broadly when you have a Twitter, when you're debating healthcare policy via, what is it, 128 characters on Twitter, you can get to a certain set of assumptions about what that healthcare might be. But really what we need to get into relatively quickly is really a set of what trade-offs you're willing to make. I mean, initially it's that you're going to pay higher taxes for it, but then it's do we it comes with well, how far are you willing to travel? How long of wait times are you willing to tolerate? In our market-based economy, I would say we have lower we have expectations of shorter wait times in this country.
You're paying for that, aren't you?
Yeah. In some cases, you're paying for you're paying for people to be sort of on call, waiting for when you might have an illness, and in some cases that can help can help healthcare outcomes by being seen sooner. But in some cases, it makes no difference whatsoever, and it's just a lot more expensive to offer that level of access. So just having an understanding that no matter what direction we go in, there are going to be trade-offs, and understanding which ones we're willing to make. And that can be challenging enough on an individual level when you start talking about coalitions of people, and that can be very difficult to build consensus. And it really does require an in-depth knowledge of both our healthcare system and international healthcare systems. Who's getting what right, and you complicating all of that is the health really of the U.S. at large. We have obesity and diabetes epidemics, and those are all going to make stress. We work more hours. And those are all going to make they're going to increase our utilization, and they're going to make things more expensive. So somehow we need to address the sort of just core health things that a system, needs to, whatever solution we're funding, needs to be guiding us towards overall more health and not just more healthcare.
And obviously, from your role with being the COO, how are you seeing technology affecting the healthcare professionals on the front line?
One popular thing to say from a doctor or nurse is that they feel like they don't nurse a patient anymore; they nurse a computer. And
Okay.
so, I missed when I was discussing Obamacare, the mandates to participate in electronic health records and health information exchanges, where you're really sharing data in a safe way between healthcare systems, so that if you are seen last month in a clinic for one system and then move across town and are seen in another system, that they have access to your records. So that has created an enormous industry for various software solutions in that space. But it has also increased the training and sort of the need for technical competency by our clinical teams. And so, if I would say there is a change in expectations. When someone thinks about going into a career in healthcare, and they say, I want to help people, think about caring for someone when they're sick, and then they're having to learn, multiple different applications in the electronic health record and become a lot more technically proficient. There can be some level of disillusionment about what the job really entails. So I think it just has raised the expectations that we have of that workforce, and we need solutions that make it easier to use the solutions that we already have in place. So, some places use, and we're trialing using scribe models, where you have scribes that follow around doctors and nurses, and they really interact with the system. But the doctors and nurses are focused on the clinical care of the patient and assessing the patient. It's certainly, I can see that there could be improvements from that, but it doesn't scale terribly well. What we really need are the electronic health records to be more user-friendly, more intuitive, and I think we're going that direction. But we're also making them more complex and building out more systems. So we're making aspects of it easier, and then we're adding more aspects to it. So that's definitely an ongoing challenge.
You mentioned as well about you talk about physicians and nurses working together. How do you see that relationship evolving over time?
I
It seems
think
to have
that we
changed over the last 5 to 10 years.
Yes. Um, I think that we have experienced tremendous improvements there. Culturally, there is more consciousness about the impact of differences, power dynamics, and the negative effects that can happen when a system is too hierarchical. So, there was a time where physicians, broadly, were not questioned to the level that they may be today. And now, whether it's doing standard timeout processes before an operating room, an operation, where everyone states their name and the role that they play on the case, and also summarizes at some level what the case is designed to do. But that's been shown. Atul Gawande talks about this, the dramatic decrease that even a simple conversation that takes a minute or less can have on reducing errors. But also just an acknowledgement that the physicians really are a part of the team, but that it takes a whole team to deliver great care. And I've been extraordinarily pleased coming back to AdventHealth. The physician partnership, whether they work directly for us or are just part of our medical staff, the physician dynamics with our emergency medicine, our hospitalists, our cardiologists, on medical oncologists, there really is a very healthy dynamic there. I think that's probably site dependent, but I think culturally we have, as we've become more aware of, how power dynamics can impact so many things, we have become more sensitive to that and more intentional about creating a voice and a space that everyone feels comfortable contributing. So I think that's been a very positive development.
And how do you sort of see the role of the nurse then evolving over the next, 10, 20 years as part of that?
Yeah, I think that we will see more specialization, subspecialization of nurses as care becomes more complex, and as a physicians, I have heard the statistic, but it is an extraordinarily high and growing number of physicians are doing more and more subspecializations in their field. And so the complexity of the nursing care is going to grow with that. And so I would expect, and more nurses are doing master's degree, and now doctorates are the expectation for many nurse practitioners and nurse anesthetists. So I think the subspecialization will continue, so that the field-specific training will be increased, and we may lose some level of flexibility to transition between nursing fields, because if you've spent 10 years learning everything you can learn about a particular field, do you really want to switch over and start over again? But I do think we want to be cognizant of what we're doing there, because if everyone is so subspecialized, then there's still it can be harder for rural or smaller community hospitals to staff, because there are fewer generalists, which is maybe what they need, and there are many more subspecialty trained, and those people, because they have done additional training, are going to want to practice at the sort of the highest level of complexity, the top of their license, so to speak. So I think we should, and that can, we could have a conversation about compensation or something that leads people to do that. But at a certain point, if we're adding more and more years of training, then the student debt piles up more, and then there's even more pressure to work wherever you're going to make the most money, and that's not necessarily the place that will make you the most happy, nor necessarily where the market has the greatest need. So we have as an example, we have an extreme shortage in our market. Our market is about 350,000 people, and we are 40 primary care physicians short of where we need to be based on national averages to care for that population. So we end up servicing a lot of those patients in the emergency department that, if they had been able to see a primary care sooner, could possibly have headed off the illness. So I just use that as an example to say it's not always that we need more highly specialized. We also need that, but in some cases we need the generalists who are taking care of the majority of our healthcare needs, and perhaps we wouldn't have such a high drain on specialties then.
That's a good point. They talk about the ward nurse becoming a specialist in itself, because that generalist is, as you say, a lot of people are going into the ward nurse will actually become a specialist, and the majority of those ward nurses, a lot of them are retiring. which is
Hmm.
kind of a big challenge we face in the UK.
Absolutely, absolutely. So, how I'm curious from your perspective, what of the conversation that I'm expressing about the U.S. healthcare system, how much overlap is there in the UK's healthcare issues?
Yeah,
What we're
a surprising amount. Yeah, I think we've got the same demographic from an aging population, a population that needs more service because it's more than one issue.
uh-huh.
When you go and see a physician now, it's not just one issue; it's two or three issues. Physicians are under a lot of pressure. Nurses are under a lot of pressure again.
Yeah,
They're specialising. They're taking on more responsibility. The cost of being educated to be a nurse at the levels that we have these days are all exactly the same challenges.
sure.
Um, this is why it's good to have different countries expressing some of the different solutions that are coming up. And I
Hmm.
think there's a similar move with the urgent care, which is trying to keep patients out of hospitals where possible, or looking
Hmm.
at wellness and things like that to avoid things like obesity and diabetes, and try and educate people to maybe not behave and look after their own health
Yeah.
before they need to, before it's a problem to go and see a nurse or a physician. There's definitely a big movement around that, around wellness and mental health as well.
Hmm. Yeah. It's interesting. A couple years back, I did some volunteer work in Haiti, and it was kind of a nice break from not that I wasn't enjoying my work, but it gets so sometimes you feel like you have gone into gridlock because you've been working in the same issues for a long time, and at that point we were sorting out sort of roles and responsibilities as part of the executive team I was on, and also dealing with how to properly incentivize physicians to deliver the highest quality of care. So I was in Haiti, and the hospital that I was working with was in Port-au-Prince. I got to sit down with the chief medical officer, and so I was asking him, Haiti and the United States are literally, I think, the poorest and the richest country in North and South America, and so you couldn't have more opposites. And so I was asking him, what challenges are you facing? So he said, well, there has been a lot of discussion and disagreement for us as a leadership team trying to figure out our roles and who does what, and we're also trying to come up with a new contract with our physicians on how to properly incentivize them. And so it was clear that some of these are just people issues and health issues. It's not always about our legal differences in how healthcare is delivered only controls so much.
No, I agree. And sort of finishing up now, Austin, I appreciate you've been busy. Thank you for the time today. Is there any message you'd like to give to our nurses watching this?
I would say that we may not always do the best job of articulating or creating the space to receive your input, but so I would say don't wait for that. Look for the opportunities to be the change that you're seeking as part of the system. If it takes grabbing an administrator or physician in the hallway and saying, hey, I see this every day and I think I have a solution for this. Don't think that somebody else is figuring that out. Push your way into the conversation, lean into it, and say, here's the change that I feel like we need to make to better take care of patients or to better take care of our nurses. Just involve yourself. Don't wait to be asked, because we need that input. We try to create space for that input, but there's still more that we don't know, and we really need your input to help us get there.
Fantastic. Austin, thank you for your time. Thank you for watching The Voice of Nursing. Thank you for all our nurses, physicians, allied health professionals and carers who look after us all. We'll catch up with you again soon.